We have spent the last hour hearing from our panelists about where the research is going in this area and what do we know or what we should do about healthy brain aging. And this part of the evening, we actually want to hear from you, as I mentioned earlier. And I guess before we sort of start asking questions to our panelists, as a researcher who actually works in area, and actually all of us around this table here work in areas where whatever work we do, it actually has a direct impact one way or another on the lives of the people. So we do research with people. There are researchers who do wonderful work in understanding underlying mechanisms of something in their laboratory, animal models, or other ways. Here we are researchers who actually talk to people, gather information, and try to come up with something that helps people in a short or a long period of time. So one of the questions that I have for you is to tell me, when it comes to brain health, what are your interests? Why are you here? What do you want to hear that you came to listen from our speakers? What do you think our priorities should be from a research perspective, from your personal experiences and areas of concern?
When we take part in the various tests and studies, like I'm one of Donna Waxman's guinea pigs, but I never find out what it was all about, what the results was. Did I do good? Did I do bad? How did we find out those sort of results?
Yeah, we actually used to have a newsletter we put out that sort of summarized papers. I mean, so ultimately what we end up doing is publishing the results. What we tend not to do, and we're regulated by our ethics board, is to give individual people their own results. You're sort of not allowed to give those out in many experiments because we're not clinically diagnosing anybody. So it's a little bit tricky. But in some of our experiments, you can see at the end how well you do, where you can hear from the beeps. Like, because some of our experiments, if you get it right, it goes beep, and you get it wrong, it goes boop. So you can tell if you get a boop, 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 it's not so good. But the problem for us is the kind of work that we do.
All these green lights and red
lights.
lights.
Yeah, because she does audition. So the problem for us is actually what we're trying to do often is put you in a place where you're not going to perform well. Because if we make the task too easy, we can't see how far we can push your system. So what we actually try to do in a lot of our experiments is get you to what we call threshold, which is the sort of the point at which you can just barely do the task. And then we're looking to see how well you can just barely do the task versus how well you can just barely do the task, and so on. But if you've got specific questions about things, just let us know.
I wondered, the last test I was involved with was putting a big hat on and testing all the different sections of my brain. And she's never called me since.
Christopher?
That was the EEG experiment, and we just haven't run another one, so don't worry about that.
I think this is a great ethical dilemma because you volunteer your time and your effort, and yet the payoff for you can be quite small, although the payoff for society and the future is very great. Exactly, but I think that Allison's point about the interpretation of the test is not the same as an interpretation of a clinical test. So if you go to a physician because you have something wrong with you and a test is done, and you are then entitled and must have the results of that test. But this is different, and partly because the test itself that's being administered to you may be an experimental test, the results of which may not have any particular clinical bearing. But I think as an investigator, it's a real ethical dilemma.
But I was actually quite excited to hear about the portal. I don't know the scope of it, but I'm hoping maybe it can be a place where we can put summaries of the research. So even if we can't give people their own individual results back,
What are you trying to
Yes,
Yeah.
yes.
Right.
So certainly that we're allowed to say, and what the overall results are across the group, we're allowed to say, but we just can't say the individuals. But we've had a problem trying to figure out how do we convey that in the best way to all of the subjects, because sometimes if we're doing a test with you now, we might actually have in mind a follow-up test, and if we tell you now, then it invalidates your ability to do the next one. So, yeah. Communication, yeah.
Right.
So I'm hoping actually that maybe we can use the portal to help to
I just
translate
wanted
what
to
you-
add to that, and I'll use the example of the Canadian Longitudinal Study in Aging, and many of you are part of that. We actually looked at this issue in a very serious way. What is it that we can give people back right away? And what is it that we cannot? Because it actually might worry you, because the information too might look that, oh, I have something wrong. You go see a doctor, and for months you are worried about that there's something wrong with me. But it might be just because the test is not a clinical test. So in our case, when people come in, we actually create a little summary sheet. We give it to the people, and we give the information for which we know there are very reasonable clinical guidelines available, where we can say, this is high, this is low, this is where you sit. Example would be blood pressure. And we don't tell you that our readings are going to be absolutely exactly you will get in the clinical setting, but if you're at a low side or a high side, just go see your physician in case they want to do further investigation and find out what's wrong or right. But there are other times we asked of information which it becomes an issue for both sides. Is it ethical to give that information, because it might actually worry you? And if we don't give it, then we are saying, how do we engage you in research? How do we keep you involved in research? And I think this is an important topic for us, for researchers, and from your participation in research, because you do give a lot of time. And it's something, as Chris, as part of our clinical working group in longitudinal study and aging, is actually continuously thinking about what is it that we can give people back right now, and what is it that we can hold back, because it does not have a clinical interpretation. We don't want people to worry. Secondly, I think the example Allison used, the tests you might be doing in the lab, actually test at one time means nothing. What we are interested in looking at the change. How do you change from your value from time 1 to time 2 to time 3? And by giving the results, you can change your subsequent reading. So scientific validity sort of goes down. Kathy, you wanted to add something to that?
Well, I also just wanted to think about the difference between clinical work and research. So if you're a clinician, you come today, you come for your appointment, and whatever I know today, I use that and I do something. I tell you something. But a scientist, it might actually take 20 years to understand what's going on. And a clinician just can't say, that's an interesting problem. Come back in 20 years when I've figured it out. So research kind of lives in another time zone. And it's because we don't know the answer that we're doing it. And in fact, some of the best days in the lab are the days when we don't have any idea why the results are turning out the way they do. Because then it makes you think about what's going on, and then you discover something new. And I'll just give you a really simple example. We take a lot of recordings of people's voices, and some people have changes in their voice as they age, and some people don't. And we are interested in hearing. So, let's find out if this person has age-related changes in their voice, how easy or hard are they to understand compared to somebody who has a more young-like voice? Well, you would expect the person with the older voice, where the voice has got a bit of tremor in it, that they wouldn't be so easily understood. So we do our experiment. Well, it turns out the person with the poor voice is better understood. And we say, well, that wasn't what we were expecting. What's going on here? And then we do 3 more experiments to try to isolate it. And it turned out that the people with the older voices were articulating, they were using their mouths to make their speech clearer. So it was an example of compensation in a motor domain that they had to make themselves understood, and they found a different way of making themselves understood because one part of their speaking system wasn't working, but the other part was in overdrive. So we learned something, but it might take us 3 years to figure that out. So we might not actually know what to tell you.
Right. And we can come back to this topic, but I think one of the obligations as researchers who are doing research in this area is to, if we are not sharing actually your personal information back to you, which might not mean anything at this point, but we do have obligation to continue to communicate with the people who are giving their time as, okay, where is this area of research going? The type of forum we have here. And I think that's important. That's something we have to do a better job in communicating because you're investing your time in providing evidence that results in wonderful data, and obligation from our side is to keep you engaged so you know your time is well spent in that fashion.
Thank you. I was particularly interested in the risks that you listed for the possible onset of dementia, but I noticed that you didn't list as a risk factor people that have a history of Alzheimer in their family, and I'd like you to comment on that. Is that because it's not a significant factor, because of course we all think it is, or is it because those previous generations could have also not been exercising, not been eating properly, so it isn't something that you can actually comment on successfully scientifically? I have another question, if you don't mind, too. My other question is, have there been any studies done on cognitive impairment as associated with menopause? I know from personal experience that when I turned 50, any mental abilities that I thought I previously had just like totally went out the window. Now that I'm in my early 60s, I actually think it just might be coming back a little bit. And I don't know whether that's because I've actually lost so much that it all looks like gravy now, or whether it actually does possibly get better after that. So menopause and genetic risk factors. Thank you.
Chris?
I'll take the first one and duck the second one. The genetics of Alzheimer's disease are quite complicated. There are two types of gene. One is a deterministic gene, which means if you have this gene, you will develop the disease. And a good example of that is Huntington's disease. If you have the Huntington gene, you will get the disease. If you don't, you're very unlikely to get it. There are some families of people who have an autosomal dominant type of genetic inheritance for Alzheimer's disease. And these people tend to be, they're very characteristic. First of all, the disease comes on early in life, and the genetic pattern is very clear. It's half the children of the person who has the disease. And these families are actually quite uncommon. Well under 10% of all the cases of Alzheimer's disease have this sort of genetic transmission. There are also probabilistic genes, and these are genes that if you have that particular gene, you are more likely to develop the disease. If you don't have it, you are less likely. But it doesn't tell you any more than that. An example of this is the ApoE system. If you have the ApoE4 allele, you're more likely to get the disease. If you have the 3-3, you're average risk. If you have 2, then you're less likely to have it. So we don't usually measure these because they're unhelpful. Even if you have an ApoE4 gene, all it means is that you're more likely to get the disease. If you have a first-order family member with the disease, for example, one parent, if that illness came on in late life, then your chances of getting the disease are only slightly greater than somebody whose parents did not have that disease. So those families where there is strong genetic transmission are very uncommon, but they're very obvious when you see them.
Yeah, no, that's great, Christopher. And I think just to add to what Christopher mentioned in relation to the late onset Alzheimer's disease and ApoE4 as a gene, if you have a gene and you have other risk factors such as poor physical activity, poor diet, it does increase your risk a little bit, but it is how your genetics, whatever the genetics you might have, interacts with your environment, the environment within which you live, might put you at a higher risk. But the risk contribution from ApoE4 is not that big. It's less than 20% or 18%. And on the hormonal side, menopause, I don't know if anyone wants to tackle that question, but what I know of some of the literature that came out in that area, that evidence is positive and negative. Some people think that hormonal changes and midlife to late midlife does have link with memory loss and dementia, and other studies have not shown it. And so I don't know if other people, I don't follow that literature, but if others have.
I'm 47, so I'm very interested in understanding more about it, but I don't know.
Yeah.
I don't think I should comment on that, but maybe that's my stage of life. I know that I shouldn't comment on that. But I wonder, though, hormones do have profound effects on behavior, and that is actually a very hot and upcoming part of psychology. So I think it is something that is actively being investigated, and also, you know, there are things that are different between women and men throughout their life, which haven't necessarily been studied very well. So, but apart from the biology of it, one of the factors that affects cognitive performance that didn't come up yet is stress. And I'm kind of wondering if, you know, there's some kind of relationship between maybe stress at that time of when you're having those hormonal changes, and then the stress affects cognition. Allison talked about the time of day, and one of the brilliant talks that I heard about stress and aging and cognition was a researcher from Montreal, and if she brings the older people into the university, the young people are very relaxed because they spend all day there. But in her lab in Montreal, she brings the university students to her lab, which is beside the community center. And then the young people are stressed out because they don't know where to park, and they don't want to stay and have tea and cookies with the research assistant. And the results flip around. And all of a sudden, when you put the person in a comfortable environment and they're not stressed out, their cognitive performance will go up. And there's also some of the social psychology is that there's something that's called stereotype threat. So if you put somebody in an environment where, you know, you're an old person, old people don't do so well on memory, then you actually do worse on the memory test. But if you do not, you know, put that in a person's mind that they're going to do poorly, then they'll do much better. So I kind of wonder if, you know, there are many things going on at that time of life, and maybe some of them are hormonal, but maybe some of them are social, and it's probably really complicated.
Can I just follow up on that very last point? It's not necessarily to do with hormones, but more the stereotyping. We just did, I don't know if people know Jay Ingram. He had a show called, what's it called now?
On Discovery? Oh, Quirks and Quarks.
And then at Discover.ca, and now the Daily Planet. And he's doing a thing called Jay's Social Experiments, and we actually just replicated one of these experiments with him on TV. It'll be airing later in February, I think. And it's a very controversial study, but it's actually, you show people words, and you have them unscramble words, and one set of the sentences has words that are more stereotypically related to older people, like Florida, honestly, and isolated, and things like that. And then the other one has just more neutral words. And what we did was we actually timed people as they walked into the room where I was testing them. They didn't know we were timing them. They thought they were just coming in to do the test. We timed them when they went out. And we replicated this effect, which is that if you've been exposed to these sentences that have Florida-type words in them, you actually walk more slowly when you leave the room than when you come in. There's a little bit of a controversy around this study right now, but we were able to find that effect in a smaller group. So these effects are profound. These effects of just, you know, thinking about things differently. So you can't really underestimate their effects.
Got a question I'd like to hear from the panel, their input on the advancements in brain research versus the onslaught of technology such as it is these days, with the many methods of communication that we have at our fingertips at all hours of the day. kind of curious to know their sense of where that might be going, how that actually affects the brain ultimately. Case in point being a 91-year-old aunt of mine living in Ottawa who has been deaf for some 20 years. Her children recently gave her, this past fall, an iPad with an app that allows you to speak into the app and it translates into text. It has changed her life dramatically. She's now emailing everybody, talking to everybody, people she hadn't communicated effectively with before, and it is really having a significantly positive effect on her life. Where do you see, if anything, the advancement of technology and how it actually might alter our method of brain study and ultimately our brains in general?
So I think that's an excellent question, because one of the things that we don't really understand is, I think Chris mentioned that as we get older, we're worse at multitasking. You know, so his daughter was able, as my son can do, to, you know, my son does his math homework while he's running a Minecraft server and watching the Daily Show. That's where he gets his news, and Skyping with his friends, all at the same time, and he gets A+, right? And, you know, I can do a little bit of that, my mom can do less, but what we don't really know is how much of that is because of a difference in age, or how much is a difference that he grew up as a digital native. So he's actually been using computers effectively since he was born, because, you know, we actually have these great family pictures at holiday time where we're all, you know, my entire family, my mom and my dad, all my kids, my brothers, everyone's like sitting in the same room on their own laptop or own, you know, cell phone or iPad or something. So my kids have grown up that way. So that's something we don't really know. The technology that's coming on, certainly for that generation, is tremendously changing the way that they interact with people, and just how they're able to process information. I think there are probably positives and negatives there. So for example, my kids don't ever have anyone over because they just Skype with them. So their interactions are different. So if we're thinking about social interactions, on the one hand, they're having quite different kinds of interactions, but if you're somebody who lives in a rural area and you can't get out anymore, you don't have the mobility, you don't have a car, it may actually be a really great way, and that perhaps is one of the things that you're finding with your relative, to engage in social interactions in a way that you couldn't before, so to start regaining some of those interactions. Similarly, I think we're going to start seeing more and more like the Google glasses coming down the pike, where your glasses are also your iPad in a sense, and you're kind of constantly doing two things at once. That's going to be a real challenge for some people who aren't used to it. I think that we've done some studies showing that you can train older people to multitask, but whether you can train them under that kind of situation, I don't know. So, you know, the technology, I think, has pros and cons. There were some heads-up displays that were put into cars, into Cadillacs in particular, a number of years ago, and the idea was to sort of, you know, for older people marketing that you can see your speed and you don't have to look down, and we're thinking that is the worst use of technology ever, because older people, if they have difficulty multitasking, and the Cadillac is being marketed primarily to the older people, they're going to crash because they're going to be looking at the speed when they should be looking at the car in front of them, and they can't kind of switch back and forth. So there's, I think, pros and cons. I think that we have to be aware that technology is changing very quickly, but one of the things that I think the technology companies have not yet figured out is that the perceptual and the cognitive and the motor needs of seniors is very, very different from that of younger users. They're designing things for my 14-year-old. They're not designing things for my 72-year-old mom, and I think they're going to have to start bringing in not just the people who are the knowledge designers for the young kids, but the population is growing, you know, in the older population, so that's where we need to see it. And the last thing, I guess, is just in terms of the imaging technologies and so on. So in my lab, we have used things like positron emission tomography and functional magnetic resonance imagery. We're planning some magnetic resonance spectroscopy studies. We do a lot of electroencephalography. It's revolutionizing the way that we're thinking about the brain, because we're able to actually now kind of see into the brain. And you can now do things that even 10 years ago you couldn't dream of doing, like online, seeing how the brain is changing as you're doing certain tasks live. You can kind of look into people's brains. People are being able to reconstruct things. So there's a group in Berkeley, some friends of ours, who can look at the brain scans and tell what you were thinking. So it's getting to a point where, you know, the systems are getting very, very complicated. But then the other thing that is changing very quickly is the way people are doing their analyses. So we used to sort of take a phrenological approach, we used to say, okay, well, this is the part of the brain that does attention, this one does memory, this one does vision, and people are now taking more of a network approach, and they're realizing that the brain kind of works like an orchestra. So yes, you've got the different instruments, but it's when you put them all together that it makes a difference. And we didn't really have the technology to be able to allow us to do those sorts of analyses before. It's really in its infancy. This is the kind of thing that some of our friends, Randy McIntosh and others at the Rotman Research Institute, have been doing, spending a lot of time doing, trying to figure out how do you understand how the whole brain works together. So we're not quite there yet, but I think the rate at which things are changing, I think that in the next 10, 20 years, what we're talking about here would be, again, completely different,
Right.
because we'll just know so much more, and the rate at which information is coming is so rapid.
Just add, I totally agree with Allison on those points, but I think we haven't yet seen things which will make a huge difference. And so hearing aids, everybody hates them, nobody wants to get one. And engineers are very interesting because they make them smaller and smaller because people want them to be invisible. But then actually old people can't see them and they can't pick them up. And they can't change the batteries, so it's kind of they're kind of a little bit down, behind on the ergonomic issues. So, I don't like to use a cell phone, but I'll use an iPad, because I can at least see what's on it and I can handle it. So those kind of ergonomics, which are more obvious to you, they're not so good on. But they have actually made fantastic progress on the software side. So the signal processing is kind of like, Star Trek. A hearing aid today has so many lines of code that it's just gone exponentially. So what would have been, a top-end hearing aid 2 years ago is kind of an ordinary hearing aid today. And if you now the engineers are talking to the psychologists, and they actually understand that just making sounds louder is not going to be good enough. And just making the signal to noise ratio better is not good enough. That in the way a person listens, you do have to pay attention and you do have to divide your attention between two things. And they will talk now about making cognitive hearing aids. And I don't, this is their ambition, is to try to put in some of those attentional processes so that the device can help the person to attend. And they have learning mechanisms in these hearing aids, so the hearing aid will learn your environments. It will learn the people that you like to talk to, and it will switch into different gears automatically for you, just like your brain would do it if you were a normal hearing person.
I guess just to add to the question, maybe if either you continue to answer, I think the part of the question was related to example of the iPad is how information communication technology actually changing the whole how people socialize. And I think it is a emerging area of research in the aging population that, even though in our longitudinal study on aging, we used to previously monitor or measure social networks, asking people how many times they phoned their friends and family members, and now we have started to gather information. Are you on a social network site? Do you contact and connect with your family members regularly, or that's how you sort of do your business? And I think that is going to have a totally profound change in how we think what the social networks are and how they function. So that might be a positive thing. I know I talk to my father on a Skype pretty much quite frequently. And even though he doesn't understand it, what it is, but it always puts a smile on his face that he sees that I am on a screen somewhere. And I think it still stimulates that whole process of engagement. And it is a very large area of research where we have to do a fair bit to understand how it impacts. Now, the other disadvantage that some of the people are talking about it, that people don't leave their homes. They become socially isolated. So issues of mobility become a challenge. So it's a emerging area, and then we will got to do a lot more. So,
how does traumatic and major stress trauma, personal trauma, and major stress affect aging, which ties into, have there been any studies about antidepressants taken long-term and how they affect Alzheimer's or dementia? And you also are going to tell us the difference between the two.
So do you want to tell the difference between dementia and Alzheimer's
Yes,
disease?
I'll do that, but I won't address the first part of that question because I think Allison and Kathy can do that better. So, Alzheimer's and dementia. Dementia is a clinical syndrome which has 4 characteristics. First of all, it is acquired. It's not something you were born with. You develop it at some point in life. Secondly, it affects at least 2 cognitive domains. Cognitive domains such as memory, language, able to recognize people, and so on. So 2 or more cognitive domains. Thirdly, it affects your ability to perform your daily activities. And fourthly, it's not occurring solely in the setting of an acute confusional state, such as some people develop after a major operation, and that sort of thing. So that's what dementia is. Alzheimer's is the commonest cause of dementia in Canada. Approximately 80% of people with dementia in Canada have Alzheimer's disease. So Alzheimer's is the specific, dementia is the general. Does that clarify that part of the question? Mm-hmm. The second part of the question was about antidepressants. There is a relationship between depression and dementia. It's quite complex. Number one, people who develop a depression late in life are more likely to develop a dementia. The first onset of depression late in life will increase the chances of developing a dementia within the next few years by 2 or 3-fold. Secondly, we have new ways of thinking about depression. In the old days, we would have been happy if the antidepressant would make people feel a bit better. Now we're not content with that. We want to actually get the person right back to the way they were before they developed their dementia, their depression. So there is a rather complex relationship between depression and dementia. Now, with regard to the question about antidepressants, some of the older antidepressants have so-called anticholinergic side effects, the sort of side effects that give you dry mouth, may make you constipated, and so on. We believe that taking some of those medications for a long time may cause cognitive problems. Often the cognitive problems will get better if that particular drug is stopped or changed to a drug with less anticholinergic side effects, although sometimes it would appear, and we don't quite understand this, that anticholinergic drugs may actually increase the risk of developing a dementia. So does that answer the question, or has that made it more unclear? Is this physical trauma or an emotional trauma? I don't think there's any evidence that emotional trauma increases the risk of dementia. I'm not aware of it.
But it might have a link to emotional trauma, might have a link to depression, and the depression itself has a complex relationship. And but I think that there are probably different types of depressions as well, which are long-term, that you sustained depression, that you have an underlying depressive etiology, versus the trauma, which might be a transient depression.
Well, certainly emotional trauma doesn't come up in any of the epidemiological studies of risk for dementia.
No, it doesn't.
I'm aware of.
No.
I understand that you can retrain the brain, right? And what I'm asking is, if you have been lackadaisical, not exercising, eating the wrong foods, and you all of a sudden find yourself not being able to remember anymore, not being able to do the tasks that you normally used to do, by changing your diet and changing your exercise regime, can you bring it back? Or is it gone forever?
There's actually some really interesting animal research that was done fairly recently here at McMaster that I think speaks to the possibilities there, where they were working with different kinds of mice that are basically bred to age very quickly. And one of the sort of groups of mice was, after they had gone along, was started to be put on an exercise regimen. And actually, the physiological measures of the mouse and some of the behavioral measures indicated that they seemed to be getting younger in a sense. So there was, in that case, and this is one very specific case and it hasn't been adapted to humans yet, but there was at least some evidence that it's not irreversible. It probably depends on exactly what state you're in. If you're in a demented state, right, then that might be different than sort of the normal healthy decline that you might see. So to some extent, whether you can recover function or not may depend on what brought you to the lack of function in the first place. Brain, as I said before, and as other people have also said, is incredibly plastic. There's actually a study that just came out last week on people who have aphasia after a stroke, which is the inability to produce, this particular aphasia is the inability to produce speech. They had been going years and years not being able to speak. They were actually given a technological intervention where they were able to read words on an iPad and hear some words presented over earphones. All of a sudden they can speak again. So depending on exactly what leads you to the state, I think some things we'll find out will be reversible and other things won't. The last thing I think on the exercise front is that the work that's been done, and there's extensive work on exercise and cognition, has shown that the benefits of exercise only last while you're exercising. So you can keep going, you can grow your hippocampus. If you stop, you're going to lose that again.
That's right.
So whereas some of the other kinds of training, like some of the cognitive training or perceptual training, we've seen in my lab some of the effects that last over a year and a half with no intervention. So depending on the kind of training that you're doing, and I think diet also can have more long-lasting effects. So depending on what you're doing, you can see longer-lasting effects, and depending on how you got to state, you might see more or less repair, I would think.
From a physical point of view, I'll just point out Mr. Fauja Singh, who completed the Toronto Marathon in 8 hours and 20-something minutes, did not start running till he was in his late 60s.
But
Actually, no, even in early 80s after his wife passed away, and he was bored and he got depressed, and he started running long distance in 80s. And he ran his first marathon at age 87. And he's not depressed, he is doing cognitively quite well. So there is some research coming in relation to your question that if you're in early stages of memory loss, such as mild cognitive impairment, it might not reverse it, but it slows down the deterioration to a next stage to somewhat. So there is some evidence of that.
So if you take on a challenge to learn something totally different that is very difficult for you to take on, is that going to exercise the brain enough to slow down this decline? Like I'm thinking if I'm taking up piano and learning to play a piano or an instrument of any kind, it's difficult to do at my age. Is it going to slow down the decay or whatever you want to call it?
I think what you need to find, so there are many studies, and doing something that's physically challenging, mentally challenging, socially challenging, and to keep on it and to do it a lot. It could be whatever suits you. One of the studies that, or potentially it could be whatever suits you. One of the studies I really was gripped by when I read, it was done in Baltimore, and it was done with black women who were lower socioeconomic class, so women who were deemed to be at risk. And their treatment, their intervention, was to become volunteers in the local kindergarten. And so they went, to read to the kindergarten children and play with them and help the teacher. And after they did that, for a term, and it was something they kept going back and doing, there were significant improvements in their walking speed, in their cognitive performance, and in their social networks. So it really was kind of an ordinary thing to do, but it had benefit.
Yeah, and there's other research that's showing sense of purpose to do something is very important when it comes to health, not just the aging brain.